so now that we're back from break, we're going to talk about peritoneal dialysis. And so here are some two popular ways to dialysize. One way in which they actually have a diacylate that they get like from a pharmacy. It's placed into the bag. They hook up to their catheter, which you can see looks very similar to a Foley catheter. They hook up, and by all means, they're trained on this. It takes a little bit of training. They have to be checked off, just like you were checked off in nursing school on things. And then they hang this bag up. It infuses into their peritoneum, okay? And then they hold that diacylate fluid in there for a period of time. It may be several hours, and it really depends on the patient. It's prescribed by the physician, okay? Then once it swishes around, osmosis and everything goes on, and it pulls out all the toxins, okay, into that fluid through osmosis. And then they're able to disconnect several hours. Then they have to hook themselves back up, use gravity, place the bag lower, obviously, than their peritoneum area, and then the waste product and the fluid drains out, and then they disconnect. And then they're instructed on how they discard their waste. That's one way to do that. Another option that they have is this fluid, instead of it being manual, like this, like a manual IV drip, instead of it being manual and using gravity, they can actually get on their machine at nighttime. And again, it is a prescribed amount of time. So they may have to be on it 8 hours at night, 9 hours at night. But what they do is the access is very similar. They hook up their machine, and it basically flows through this machine into the patient's body while they're sleeping. And then it actually drains back out, and then they wake up and it's done. And the good thing about that is it frees up their mobility during the daytime. If this is the option that they choose, it's definitely a lot simpler, but they usually have to do that multiple times a day. So you can tell definitely a lot of interruptions to their activities of daily living. Main thing too, we want to definitely be sure that we talk about skincare. They need to really take showers. Remember, that's an open stoma. And so we don't want them in the tub or a lot of water to build up. We want to make sure that's open to air just to keep it dry. We want to keep the fungal infections, bacterial infections, any skin breakdown to a minimum, or really we don't want it at all. They also need to understand that diacylate exchange, if they're talking about the manual hookup, it takes about 30 to 60 minutes. And so this, like for the inflow, it may take about 10 minutes. So they're hooking themselves up. It takes 10 minutes for that bag to go in. The dwelling part, that's where it swishes around in their belly. And they can go along with their business, I don't know, get on their computer, wash dishes when that's going on. And then whatever the prescribed amount of time is, then the drainage takes about 20 to 30 minutes, okay? And so we just want to be sure that they, are prepared that that is a process. It takes time. So the actual diacylate exchange, which is the inflow and the drain, takes about 30 to 60 minutes. So they would need to allow time in their day for that. So like, for instance, if they want to go to the park with their grandkids or close by, or go outside and work in their water their flowers, they have that many hours to work on that, but then they need to be back home and allow that time for drainage, okay? So again, this is where they place themselves in the machine. This is called continuous cycling peritoneal dialysis. And again, the benefits of this, both of these things are done 5 to 7 days a week. This one again is strictly done usually at night, frees up their day. The other one's done 3 or 4 times a day, okay? And then we're going to talk about the main side effect, of course, is infection, peritonitis, and we want to watch our patients for those types of symptoms, like a change in vital signs, over distension, a rigid abdomen, the feeling of fullness and uncomfortableness, okay? And we've already talked about peritonitis before, already done a case study, so I'm not going to really get into that, okay? Our next activity that we're going to do is I'm going to bring up a case study chart in EHR Tutor. So let's go ahead and break for that, and then we'll come back and review that case study, okay? A more like yellowish, pale yellowish kind of just discolored opacity if it's from peritoneal dialysis, whereas more kind of that dialysis is 2 ways. So, right. Okay, so we're back from break, and we talked about y'all going ahead. Some of you, you're welcome to pull up EHR Tutor. You can just go to your ATI account, go into the course and pull that up so you can follow along if you want to, or you can take notes on paper, whatever you want to do. But we are going to talk about this case study, which is Miss Anna Sophia Swisher. Obviously it's a fake patient, but she has chronic kidney disease. And so a little bit of background on her is she normally does peritoneal dialysis, and what happened is she said it just wasn't working. She was having trouble with it, and she noticed that she had some weight gain. She was kind of short of breath, really exhausted, and that's kind of what brought her into the hospital, okay? And so we're gonna kind of scroll through some of these vital signs slowly and look at those. We're gonna review some of these orders. It looks like activity ad lib. She got admitted, she's on aspirin. Atorvastatin, she had some labs drawn. Blood glucose, looks like she's on an IV antibiotic. Oh, she's gonna have a central line placement while she's here. This is probably just a surgical scrub for that. Daily weight, and then there's some of her labs. Okay, so let's look at, I think we can look at her labs a little bit better. If we go to these results, it kind of gives a better picture of it. So, all right. So we're looking at these labs, and we want to look at some things that are maybe like abnormal. What are some things that are some red flag? And so like starting off, I noticed that her white blood cell count, we know that that's elevated. She's on an IV antibiotic. Now we're not really sure. In the summary, it doesn't say what infection she has or what's going on with her. But what are some other labs that look a little off to you? Yes.
Her red blood cells and her H&H are low.
Yeah, they're low. And why, like for this specific patient and what we know about her, why do you think it might be low? Her chronic kidney disease. Very good. So we know chronic kidney disease, they tend to be anemic and definitely would have those low lab values, okay? Looks like her platelet count is good. As we're scrolling down, what are some other things that you might see that are concerning or abnormal, basically?
Her glucose and her A1C is high.
Yes. So her hemoglobin A1C, her glucose are elevated, and what does that indicate, Gabby?
The glucose being high is probably from her type 2 diabetes, and the A1C, maybe the diabetes is uncontrolled.
Yes, so probably uncontrolled. So we know that basically is a reflection of her 3 months glucose control. All right. So what are some other labs that you see?
I was scrolling through and I see that her potassium is elevated.
It is really high. So why do you think it's high?
Probably because of the chronic kidney disease. And so we probably should think about checking for the T-waves and looking at those and maybe putting her on a cardiac monitor.
Yes, definitely. We definitely want to address that pretty quickly. Yes, Emily.
Could we also look at like her medications? Maybe she like on that diuretic, like Caxilate?
Oh yes, very true. So like she may be a diuretic that would actually decrease the potassium, but K-exalate, we could see, hey, did they prescribe K-exalate? Because that may help the potassium. It would bring it down. So yes, very good. Okay, we could review those meds in a little bit. Okay, what are some other labs that are a little off?
Her phosphate's kind of high.
Yeah, her phosphate is high. And why would it be high?
Just the
Yeah, just the chronic kidney disease. Their diet is usually limited on phosphates. We know calcium and phosphorus kind of go together, and so they may have a decrease in dairy consumption. Those are high in phosphates along with some other foods. Very good. Is there anything else that looks out of whack?
her protein and her albumin's low.
Yes. So why do you think that's low?
Just the same with her kidney disease.
Yeah, again, same. Chronic kidney disease, they have low protein levels. Okay, very good. Anything else before we move on? Okay, so one of the other things is the BUN and creatinine. If you notice those things, the creatinine and the BUN are definitely elevated. And so what are some reasons why what does that indicate? Yes, Judy?
These are a sign that kidneys are functioning.
Yeah, it's definitely a sign the kidneys are not functioning. And again, we know she's got chronic kidney disease. And so we definitely want to look at that. Okay, so we're going to go across and let's go ahead and skip over to meds like Emily talked about. And so we want to review some of these meds. She's on aspirin, atorvastatin. We're just going to review those really quick and then we're going to go into her history. So I'm going to scroll down and I just kind of want you to take a mental note of these medicines. She's on losartan. And then we're going to talk about gentamicin. Looks like that's for her catheter site. Glipizide, furosemide, Lasix, gabapentin. She's on an ointment, sevelamer, prednisone. And so we're going to look after we scroll through these. Let's go ahead and look at her history and kind of find out why she might be on some of these medicines. So on chief complaint and history, so again, the client, we can read this. The client reports difficulty completing peritoneal dialysis due to a recent weight gain of 13.2 kilograms, which
That math is not right tonight. For your pounds and your kilograms.
yeah, it does look a little bit funny.
Should be, 3 kilograms, but it's 0.6 grams.
Oh yeah, it should be 3 kilograms. So there's an error in the chart. So you're right, very good. It should be 3 kilograms. So that's definitely, so if that's something, if you see an error like that, you would definitely want to kind of probably reweigh the patient and see if it was just, did they type it in wrong or they just, or was it really they didn't record the, we might want to reweigh them. Okay. So into their other history, we're going to go through these past medical histories and we want to look at some of these diagnoses and figure out, are some of these diagnoses already being treated? So let's visit with hyperlipidemia. Did you see anything on our medication list where that's being basically taken care of? Okay, atorvastatin, very good. That's for high cholesterol. It's an AMG reductase inhibitor. And I did notice their liver enzymes weren't good. Okay, what else? Chronic kidney disease. Anything really related to that?
Anemia, she's taking an iron.
Oh yeah, so with the chronic kidney disease, she is anemic and yeah, she does have that iron supplement. That's very good. All right, what about diabetes mellitus 2? We know she's getting NACI checks. Is she already on medications for that? Yes, Emily?
Isn't glipizide doesn't that stimulate like the beta cells?
Yeah, it does. It stimulates the beta cells, so very good. So she is on a type 2 anti-diabetic medication, okay?
As well as, I don't know if I'm saying this right, but linagliptin.
Yeah, I don't even know if I can say that right. Linagliptin, yes, that's another one. And that actually stimulates the natural substances in your body and also stimulates the pancreas. So, very good. All right, so what about hypertension? Is that being taken care of?
Yeah, she's taking Lasix and losartan.
Yeah, so she's taking Lasix and losartan. Both of those could be used to treat hypertension, okay? Yeah, uremic pruritus, and we've talked about that before in lecture. So when their urea levels get high, it makes them super itchy. So she's definitely on a kind of an immune ointment to basically decrease her response to that. What about peripheral neuropathy? Is she on any medication for that that's being treated?
It looked like she was on gabapentin and tramadol.
Good. So gabapentin we know is kind of the gold standard used to treat peripheral neuropathy, and if the pain is so severe, right, the tramadol will kind of cover that. That's a little bit more painful. Very good. Okay. And reviewing her surgical history, it looks like kind of on the same day she had both an AV fistula placed and a peritoneal dialysis catheter placed on the same day in May, and of course he said there it was ready to use. So we know that she used peritoneal dialysis. It didn't really mention that she went to a kidney dialysis center. Like, is it unusual? Is that normal for them to have both surgeries done, for them to have both a shunt and, or a fistula and a peritoneal dialysis? Like, what are your thoughts on that? Yes, Carla.
Well, officially, she's using the peritoneal, but when the AV port be used as a backup just in case.
Yeah, that's very good thinking. They would probably really, some nephrologists choose to do that because they want a backup, okay? So,